and we know what that can do. GP commissioning, fur coat and no knickers. And I think it came out. These guys who treat coughs and colds and don't know and wear different colored socks on the same day, how can they do commissioning? And absolutely right, how can we? And every GP is not going to be a commissioner. And I think in the last few months since the GP commissioning has come out, we're rapidly developing attire which will cover us up properly when the fur coat comes off. So I think the fur coat is going to come off in the very near future for definitely by 2012 onwards it has to, and as a pathfinder probably a little bit earlier. So why GPs? GP's ability to extract information from patients, unpick complex problems, influence behaviors, and manage the risks of a range of solutions. Barbara Haken. This is before she became the chief exec of her own PCT, then SHA, now the managing director for development of commissioning, and she was a GP. So, hey, if one person can do it. GPs see 1 million patients a day, and they know where services succeed and fail, and what to do to improve them and to landlessly. So that's why I think GPs should do it. Organization, memory, shared fate, and big stakeholders. I live in the community I serve, and I've been there for 20 years. I've been part of a system, and I share the fate with my patients. Why would I want to do them harm? So, but in Crawley, where I come from, I'm the only one there who has any organization memory of the changes we've gone through. All the managers have left in 1.5 years, 2 years, and gone away. So the only one who can tell them what Bagnall Review did in 1998 to 2000 is me, who can tell them about something else. So not because I'm very clever, it's just that I've been in the same place for a very long time, and people have moved on to bigger and greener pastures. And some of us have been in apprenticeship for a long time, and myself, I've been doing clinical governance, then did diabetes, PCT, PEC chair, medical director, did some work with Department of Health with the SHA. And a lot of my colleagues have done stuff like that. So for 10 years, we've been apprenticeship in doing policy, population, and partnerships. Why are we different? But we've been doing commissioning. So it has been a management apprenticeship, not providing apprenticeship. I haven't been learning how to become a surgeon. It's been about delivering better population care that we've been doing. But it's all about leadership. And you can judge for yourself who are the good ones and the bad ones, and who can communicate and who spectacularly can't. But leaders are leaders. Anybody can be a leader. But leadership, there are many definitions of leadership. But leadership is ultimately about creating a way for people to contribute to making something extraordinary happen. And what we're being asked to do, as you heard from David, was to do something extraordinary, because this has never been done before. And so we will need good leaders. And what about leaders? This man came, and 2,500, 250,000 people came, 20% of them were whites, because they identified what his message. It was not, he just said, I have a dream. He didn't say, I have a plan. Because he was telling them why we should do stuff. Why we're all here is to improve the health and well-being of the populations we serve. What we do to get them there might be shared across some platforms and so on, or not. And how we do it will be completely local. It'll be different in my surgery, it'll be different in my locality, and it'll be different in the region. So we have to be clear why we're there, the what and how will follow, but we have to be very, very clear. Because we have mixed up some of our currencies. The currency in health, and when I sat on a board, was all about financial balance. As an NHS service, we were not talking about patients. 90% of the time we were talking about hospitals and financial balance, when the currency should be health and well-being and how many people will got better. Of course we have to look at the resource. That's part of the deal. But we can't have just one currency. And of course, if you have to be good leaders, we have to tell what the dream is. We have to be able to tell a good story, because people listen to us. And people are interested in the message, but we also have to understand as a GP commissioner, just because people have given me the Superman costume or a Supergirl costume, not me personally, but others might have, it doesn't mean I can fly. I still am on a learner driver, and I think we have to be, and I'm difficult and arrogant, and even I understand this, that I need my specialist colleagues sitting by my side while I'm learning how to drive, and next year or two I might learn how to do it or not, or I might fail, and if I fail, I shouldn't be doing this, because it's a really important job. And there are lots of people who've done it well and some very badly, and we learn from the ones who drive well. So that's, or fly well. So but it's best to, most fun to fly with friends. I just want to clear up, that was just now I tried to comment. It is because it's a GP-led commissioning. I need my district nurses. I need all the collective intelligence of my clinical colleagues in the hospitals, from social services, the third sector providers, people who work, for us to commission well. Because it's around registered population and because they're called a GP commissioning, it wasn't one of our favorite names, but hey, there it is. But we are very keen to look at GP commissioning as a way of, and our job is to find clinical solutions to financial challenges and not financial solutions to clinical consequences, because I, as a clinician, create the mess sometimes. What do the GPs say? This is the NHS Alliance. Don't look at the numbers, they were relatively small, but what they were saying was GP commissioning consortia should hold formal responsibility and accountability for all those areas that they commission. And about 90% said yes. The national outcome framework must create sufficient flexibility so that local priorities as well as national must-dos can be delivered. Almost 97% or 98% said yes. And when you say there should be a strong relationship between GP consortia and local authorities through local health and well-being boards, about 85-90% said yes. And GP commissioning consortia need to ensure that they involve patients and patient groups and patient insight in their commissioning decision. Another 90% said yes, approximately. So GPs have no intention of taking over the world. It is about working with local people. It might be just we have very nice colleagues in the NHS Alliance, but that's what they were saying. The other bit is coming out that we have to make 1 + 1 = 5, which is we have to make the money work as consortia. And as part of the group that met the GPs and local government at the national level a couple of weeks back, and absolute agreement with the Local Government Authorities Association that we need to devolve public health to the government. We must have clinicians on the health and well-being boards, and public resources must be directed to the areas with greatest needs, so health inequalities area, and we must build on what we've done well rather than dismantle it. And the way it was going to be done, the science behind it, because it's all in good warm words, this is Chris Bentley's slide, which is he calls a Christmas tree. So if we define the optimal population outcomes, then on your right-hand side is what the clinicians would do, and on the left-hand side is what the local government would do with us. But we work together to deliver the middle bit, which holds it all up together. The wood won't go through, and it takes an hour to do this properly, but we'll. But if you look at, as a commissioner, I want to know if there's a return on investment. Public health is all very good, but when am I going to get my money back if I do this? Because we only have that much money. So some of the science behind this, and we were talking about this on Tuesday when we met, or Monday when we met him, was to define very clearly when is it 1 year return on investment, 5-year return on investment, 20 years return on investments? We need to know. So we can put the appropriate amount of money. So there's science behind that. It's people who make the chicken. This is from Nando's. I guess if you have children, you would have gone to Nando's. And there's Professor Laurie Santos is a professor of psychology in Yale. And she and the other cousins of mine are Capuchin monkeys. And they're about 30 million years back. What she was doing was, very briefly, she said, do human beings make mistakes because we are so complex and wonderful and intelligent, or do we make the mistakes because it's hardwired into us? And she did an experiment with money. In the end, what came out was, when it comes to risk, So she taught the Capuchin monkeys to use money. And what came out was that when it comes to risk and loss awareness and our behaviors to loss, the monkeys and the financial broker type of people, the qualitatively and quantitatively did exactly the same thing.